Hemangioma. D. Ruptured dermoid cyst. E. Rhabdomyosarcoma. 22. LE Beatty CA and Sakai O. Non-traumatic orbital conditions. Diagnosis with CT and MR imaging in the emergent setting. Radiographics 2008, 28, 1741-1753. 21. E. Rhabdomyosarcoma. The clinical and radiological features described are typical of rhabdomyosarcoma. It usually presents in the Phi-RST decade of life with a rapidly growing mass causing proptoses. The globe is often distorted and displaced but rarely invaded. The lesion is aggressive and there may be extension into the sinuses or intracranial compartment, and bony destruction can occur. NHL is usually found in older adults, but it can occur in older children or adolescents. Unlike rhabdomyosarcoma, NHL commonly causes lacrimal gland involvement, may be hypointense on T2WI, and in cases rather than distorts the globe. Capillary hemangioma typically presents in the Phi-RST few months of life. They have a proliferative phase for approximately 12 months following diagnosis, and then are stable, before gradually involuting over a period of years. These lesions show rapid and persistent enhancement on CT and MRI. On unenhanced MRI, it is typically ISO, to hyperintense relative to muscle on T1WI, and moderately hyperintense on T2WI, with fluid ovoids at the periphery of or within the tumor. A ruptured dermoid cyst can mimic a rhabdomyosarcoma both clinically and radiologically, but one might expect to see calcified cation or fatty or cystic components in the native lesion. Retinoblastoma is an intraorbital lesion. Chung M. Smyrniotopolos JG, Spec CS, Schroeder J. JW and presentation. A 10-year-old girl presents with gradual onset proptoses in the left eye and is noted to have restricted left eye movements. An MRI scan is performed and this demonstrates a poorly circumscribed lobulated lesion that involves both the intraconal and extraconal compartments. The lesion has mixed signal intensity on T1WI, with areas of increased and decreased signal. It is mostly of increased signal on T2WI, and there are areas containing FLUID level. Post-contrast, there is heterogeneous enhancement. What is the most likely diagnosis? A. Venous lymphatic malformation. B. Orbital varix. C. Cavernous hemangioma. D. Capillary. Presentation in childhood. MRI is the modality of choice for diagnosis, as FLUID levels are almost pathognomic of this condition, and these represent areas of hemorrhage of varying ages. The MRI Phi endings are as those described, and there are typically no large feeding vessels, or FL ovoids. The lesion is predominantly extraconal, but can insinuate into the intraconal compartment. Capillary hemangioma also presents in childhood, but may be apparent clinically, and on MRI there are not typically fluid FLUID levels, but there may be FL ovoids within the lesion from prominent vessels. Also, enhancement is usually more rapid and persistent in capillary hemangioma than in venous lymphatic malformation. Central nervous, head and neck answers 267. Orbital varices usually present in young adults, and on imaging have the appearance of dilated, tortuous vessels. Cavernous hemangioma typically presents in adulthood. They are usually well circumscribed and most often occur in the lateral aspect of the retrobulbar intraconal space. On CT, they are slightly hyperattenuating prior to contrast and may contain phleboliths. On MRI, they are ISO intense to muscle on T1WI and hyperintense on T2WI. They show progressive enhancement on multiphase dynamic imaging. Hemangioblastoma are rare vascular tumors that are more often seen in adults than children. Large lesions may show bony erosion, and they do not typically have fluid FLUID levels on CT or MRI. Smoker work, Gentry LR, YNK. Capillary hemangioma. E. Hemangioblastoma. 23, a 20-year-old female. Female with a history of neurofibromatoses presence with reduced visual acuity in the right eye. She subsequently has CT and MR imaging of the orbits to assess for a tumor relating to the right optic nerve. Which of the following 5 endings on imaging would be more suggestive of the presence of an optic nerve glioma, rather than a meningioma arising from the optic nerve sheath? A. Presence of the tram track sign. B. Presence of optic canal widening. C. Presence of marked intense tumor enhancement. D. Presence of calcified cation. E. Presence of bony hyperostosis. NK, read DL, and Neurad JA. Then meets the eye. Radiographics 2008, 28, 185-204. 23, B. Presence of optic canal widening. The presence of a widened optic nerve canal occurs in up to 90% of cases of optic nerve glioma, while it can also occur in meningioma. Meningioma, it is more common in glioma, and some cases of meningioma may even have a narrow canal secondary to bony hyperostosis. The tram track sign is typically associated with meningioma, and refers to the more avidly enhancing meningioma surrounding the non-enhancing optic nerve on axial CT. CT and MR imaging of the orbit. Although both meningioma and glioma enhance following intravenous contrast, it is meningioma that is more typically associated with marked intense enhancement. Calcified cation and bony hyperostosis are features associated with meningioma. Calcified cation is rare in gliomas, unless they have previously undergone radiotherapy. Central nervous, head and neck questions 245. 24, a 45-year-old man has a severe head injury and is noted to have a left facial nerve palsy. Following stabilization, a subsequent HRCT scan of the temporal bone is performed. This demonstrates a fracture of the left temporal bone, involving the course of the left facial nerve. Which orientation of fracture and which segment of the facial nerve are most likely to be involved? A. Transverse/internal auditory canal. B. Longitudinal/internal auditory canal. C. Transverse/labyrinthine. D. Longitudinal/labyrinthine. E. Transverse/mastoid. F. Longitudinal/mastoid. 25. A 42-year-old woman has a CT scan of brain performed for the investigation of headache. A lesion with density similar to cerebrospinal FLUID is noted at the right cerebellopontine angle. A subsequent MRI scan is performed and this shows that the lesion is well-defined of decreased signal on T1WI and increased signal on T2WI. You think the lesion is most likely an epidermoid cyst, but wish to exclude an arachnoid cyst. Which of the following further MRI sequences will be most helpful in achieving the same? A. Proton density. Aviv R.I. and Miskiel K. Orbital imaging PART2. Intraorbital pathology. Clinical radiology 2005, 60, 288307. 24. C. Transverse/labyrinthine. Transverse temporal bone fractures are more commonly associated with facial nerve paralysis, approximately up to 50%, than longitudinal temporal bone fractures, approximately up to 20%. The labyrinthine segment is the most likely segment of the facial nerve to be associated with facial paralysis. Jaeger L. and Reiser M. CT and MR imaging of the normal and pathologic conditions of the facial nerve. European Journal of Radiology 2001, 40, 133-146. 25. D. Flare. On a flare sequence, epidermoid cysts can be differentiated from arachnoid cysts because the former show mixed ISO to hyperintense signal, but with poor demarcation, while the signal of the latter is suppressed, like the signal of CSF. DWI offers a phi ending specify C for extraaxial epidermoid cysts by showing very high signal. Restricted ADC compared to CSF, almost comparable to that of the brain and T2 shine-through effect, both play an important role in the high signal intensity of epidermoid cyst at DWI. This can therefore be useful in helping to distinguish them from arachnoid cyst. Bonneville F. Savatowski J. and Cheris J. Imaging of cerebellopontine. 268 central nervous, head and neck answers. Density. B. Stir. E. T1 post-gadolinium. 26. A 45-year-old man presents with a 4-month history of worsening lower back pain radiating into the right lower extremity with weakness. An MRI scan of lumbar spine shows a 3 cm well-defined net ovoid lesion eccentrically placed at the conus medullaris, the location of which is felt to be intradural and extramedullary. It is hypointense on T1WI and hyperintense on T2WI. There are fluid ovoids and hemorrhage within the lesion. It enhances avidly post-injection of contrast. Which of the following lesions phi TS best with the imaging phi endings? A. Meningioma. B. Schwannoma. C. Neurofibroma. D. Paraganglioma. E. Metastasis. 246 central nervous, head and neck questions. 27. A 40. Answers. 26. D. Paraganglioma. Paragangliomas are rare intradural extramedullary tumors that are usually benign and have imaging characteristics as those described. Schwannomas, neurofibromas, and meningiomas are much more common, but do not typically contain vascular FL ovoids or areas of hemorrhage. Meningiomas may have a dural tail or foci of calcified cation. Schwannomas and neurofibromas can be difficult to distinguish on imaging. They are typically isointense on T1WI and markedly hyperintense on T2WI. Enhancement may be intense and homogeneous or peripheral. Neurofibromas tend to encase, rather than displace, nerve roots. Leptomeningeal metastases present with 3 different imaging patterns: 1. Diffuse, thin enhancing coating of the surface of the spinal cord and nerve roots. 2. Multiple small enhancing nodules on the surface of the cord and nerve roots. 3. A single mass in the lowest part of the thecal sac. Abulkasim K., Thurner M.M., McKeever P., and Sundgren P.C. PC. Intradural spinal tumors, current classified cation and MRI features. Neuroradiology. Year-old woman presents with a several-month history of neck pain and gradually progressive weakness and paresthesia in the upper limbs. An MRI scan of the cervical spine is performed, and this shows a well-defined and central intramedullary mass in the mid-cervical spinal cord. The mass is generally slightly hyperintense on T2WI, but also has a few low-signal peripheral areas. It enhances homogeneously with gadolinium. What is the most likely diagnosis? A. Astrocytoma. B. Metastasis. C. Hemangioblastoma. D. Ganglioglioma. E. Ependymoma. 28. A 30-year-old male patient attends A&E 30 minutes after a head injury. Abulkasim K, Thurner MM, McKeever P, and Sundgren PC. Intradural spinal tumors, current classified cation and MRI features. Neuroradiology 2008, 50, 301314. 27. E. Ependymoma. Ependymoma is the most common intramedullary neoplasm in adults. It tends to be centrally located within the cord, unlike astrocytoma, which can be eccentric. Astrocytoma can have a longer segment of cord involvement than ependymoma, and may have a more infiltrative margin. The peripheral low signal areas seen on T2WI in ependymoma are related to hemosiderin deposition from prior hemorrhage. Hemangioblastoma is more often seen in the dorsal cord than the cervical cord, and is typically a small well-defined NED lesion. It may have an associated cord cyst or syrinx. Flow voids may be seen within the lesion from dilated vascular channels. Ganglioglioma is a very rare, slow-growing tumor of low malignant potential. The imaging appearance is non-specified C, but there are some phi endings that may suggest the diagnosis. Compared with other spinal cord tumors, gangliogliomas are more likely to involve long segments of the cord greater than 4 levels, up to the whole cord, to be associated with bone erosion or scalloping, to have tumoral cysts, and to have areas of mixed high signal and pre-contrast T1WI. Intramedullary metastasis represents less than 5% of intramedullary lesions. They usually occur in the setting of advanced malignant disease, typically from a lung or breast primary. The spinal cord edema can seem out of keeping with the small size of the metastatic lesion. Smith J.K., Laurie K., and Castillo M., Imaging of spinal and spinal cord tumors. Injury. He has consumed alcohol. You are contacted by the A&E doctor, who requests a CT brain. At this time, which of the following is a correct indication for immediate scanning? A. 2 episodes of vomiting. B. GCS 13. C. Loss of consciousness. D. Amnesia for 20 minutes before accident. E. Visual hallucinations. 29, A27, year. 28A. 2 episodes of vomiting. Almost anything will buy you a CT brain these days, but surprisingly, the GCS must be less than 13 in the A&E department within 2 hours of the injury under NICE guidelines to warrant one. After 2 hours have passed, a GCS of anything less than normal is an indication for scanning. Other factors which require a CT within 1 hour are suspected open or depressed skull fracture, sign of fracture at skull base, post-traumatic seizure, focal neurological device CIT, and amnesia, or loss of consciousness and coagulopathy. Additional factors which necessitate a CT brain within 8 hours are amnesia of events for greater than 30 minutes before impact, and if there is any amnesia or loss of consciousness, and the patient is older than 65/dangerous mechanism of injury. Note that, perversely, even if the scan can be delayed but be performed within 8 hours, the guidelines state it should be requested immediately. Prepare to be awoken from your sleep. Central nervous, head and neck answers 269. NICE guideline on head injury, triage, assessment, investigation, and early management of head injury in infants, children, and adults. September 2007. E. Visual hallucinations. 29, A27, year, old female patient undergoes urgent neuroimaging following loss of consciousness as a result of an RTA. CT is unremarkable. MRI reveals multiple small areas of increased signal on T2WI in the white matter near the gray white matter junction within the frontal and temporal lobes. In the same locations, DWI reveals areas of increased signal on the B1000 image and reduced signal on the ADC map. What is the most likely diagnosis? A. Subarachnoid hemorrhage. B. Extradural hematoma. Hematoma. C. Subdural hematoma. D. Hypoxic brain injury. E. Diffuse axonal injury. Injury in infants, children, and adults. September 2007. Quick reference guide. Available online at http://www.nice.org.uk/nicemedia/live/11836/36257/36257.pdf http://www.nice.org.uk/nicemedia/live/11836/36257/36257.pdf 29. E. Diffuse axonal injury, DI. CT is initially often normal, up to 80% of cases in DI. If positive, it may reveal small low attenuation foci, edema, or high attenuation foci of petechial hemorrhage. The gray/white matter interface of the frontotemporal lobes, corpus callosum, especially the splenium, and brainstem, are the most commonly involved sites in DI. MRI is much more sensitive, and is the investigation of choice. The signal on MRI depends on the age of the lesion, and whether hemorrhage is present, but classically hyperintense foci on T2WI sequences are seen acutely. In the more chronic phase, the lesions may only be detected as hypointense foci at characteristic locations on GE sequences. This appearance may remain for years. DWI reveals hyperintense foci of restricted diffusion on B1000 images, with corresponding low signal on the ADC map. The map. The phi endings on DWI are easily distinguishable from extradural hematoma/subarachnoid hemorrhage/subdural hematoma/generalized edema, which are discussed in other questions in this chapter. Osborne A.G., Blaser S.I., Salzman K.L., Katzman G.L., Provenzale J., Hedlund G.L. ETAL Diagnostic Imaging, Brain, A. Mirces, 2004, I2, 3033. 30, D. A 34-year-old man undergoes MRI of brain after admission for head trauma. Which of the following sequences is most sensitive for subarachnoid hemorrhage? A. T1WI. B. T1WI with fat saturation. C. T2WI. D. Flare. E. Proton density. Osborne A.G., Blaser S.I., Salzman K.L., Katzman G.L., Provenzale J., Hedlund G.L. ETAL Diagnostic Imaging, Brain, A. Mirces, 2004, I2, 3033. 30, D. Flare. Although CT is generally used for investigating acute subarachnoid hemorrhage, SAH, flare sequence on MRI has been suggested as being as sensitive as or more sensitive than CT. It is particularly useful in regions where CT may be limited due to beam hardening artifacts, or if there is a very small amount of blood. Acute SAH appears as high intensity on flare within the cisterns and sulci. Subacute SAH may be better appreciated on MRI because of its high signal intensity when the blood is isointense to CSF on CT. SAH differs from intraparenchymal hemorrhage in that the mix of blood with high oxygen tension CSF delays generation of paramagnetic deoxyhemoglobin, and oxyhemoglobin remains present longer than in intraparenchymal hemorrhage. This contributes to continued T2 prolongation. Beware that there are other pathological, meningitis, leptomeningiomatastases, acute stroke, fat-containing tumor/dermoid rupture, and benign artifact, supplemental oxygenation, causes of flare hyperintensity in the subarachnoid space. Chronic hemorrhage from SAH is best detected on GE sequences, resulting in marked subarachnoid low signal, the blooming of superficial side rosses. Stucky SL, Go TD. Central nervous, head and neck questions 247. 31, a 58-year-old patient is found at home with a reduced GCS. CT brain reveals atrophy only. MRI brain reveals hyperintensity in the tegmentum, except for the red nucleus, and hypointensity of the superior colliculus on T2WI, as well as hyperintensity in the basal ganglia. What is the most likely cause? A. Cocaine abuse. B. Methanol poisoning. C. Primary basal ganglia hemorrhage. D. Wilson's disease. E. Carbon monoxide poisoning. 32, a 27-year-old man suffers a head injury. A CT brain. Stucky SL, Go TD, Heffernan T. 31, D. Wilson's disease. Hyperintensity in the tegmentum, except for the red nucleus, and hypointensity of the superior colliculus are described as the face of the giant panda sign, and are seen in axial T2WI sections of the midbrain in Wilson's disease. A double panda sign has also been described, with a second panda cub face in the pons. Abnormal signal can also be seen in the basal ganglia and thalamus in Wilson's disease, putamen most commonly. The signal abnormalities are due to copper deposition. Signal is generally reduced on T1WI sequences, although it may be increased due to the paramagnetic effects of copper, and also due to the hepatic component of Wilson's disease. A portocable shunt can produce this latter phi ending. Signal is generally increased on T2WI sequences, but it can be of mixed or reduced intensity. Similarly, carbon monoxide poisoning and methanol poisoning can cause increased or reduced signal on T1WI. Methanol poisoning typically causes abnormal signal in the putamen, with hemorrhagic necrosis being more typical, whereas carbon. 270 central nervous, head and neck answers. Monoxide poisoning typically affects the globus pallidus. Pallidus. The latter would be expected to cause low attenuation in the basal ganglia on CT. The phi endings on CT exclude basal ganglia hemorrhage. Amphetamine and cocaine abuse can cause high T2WI signal in the basal ganglia due to small areas of infarction, but are not associated with the midbrain changes. Jacobs. Brain is performed. Which of the following features favors a subdural hematoma, SDH, over an extradural hematoma, EV? A. The hematoma measures 50 Hu. B. The presence of a temporal skull fracture. C. The hematoma crosses the midline over the falx. D. The collection has a biconvex configuration. E. The hematoma crosses sutures. Disease. Neurology 2003, 61, 969. 32, E. The hematoma crosses sutures. An SDH will cross suture lines and may extend over the whole cerebral hemisphere, an EV will not. Only an EV can cross the midline, and this usually occurs at the vertex in the setting of a venous EV. EVs are more usually arterial bleeds and associated with temporal skull fractures, which disrupt the adjacent middle meningeal artery. The latter are typically biconvex, SDHs are typically lentiform in shape. Both measure 50-60 Hu with acute. Chronic SDHs may be ISO, or hypodense to brain, although anemia or clotting disorders can produce a similar appearance. EV is a neurosurgical emergency. Emergency more so than SDH because of the potential lucent period followed by sudden deterioration as arterial bleeding continues after having stripped the dura from the inner table of the skull. Bar R. 33. A 65-year-old woman with a history of previous subarachnoid hemorrhage presents with slowly progressive cognitive decline and worsening gait. A CT brain reveals ventricular dilatation with rounded frontal horns and periventricular hypodensity. What is the most likely diagnosis? A. Heavy metal toxicity secondary to aneurysm clip. B. Parkinson's disease. C. Alzheimer's disease. D. Normal bar RM, gene AD, and Tuong HL, craniofacial trauma. Normal pressure hydrocephalus. 50% of cases of normal pressure hydrocephalus, NPH, are idiopathic, while 50% have a cause, e.g. meningitis, neurosurgery, head trauma, or, as in the current vignette, previous subarachnoid hemorrhage. The imaging reveals dilated ventricles with rounded frontal horns, which are enlarged out of proportion to the degree of sulcal enlargement, as one would see in cerebral atrophy. On CT, there may be periventricular low attenuation in the frontal and occipital regions, representing transependymal CSF FL. The MRI equivalent is periventricular high signal, and there are other MRI phi endings, including upward bowing of the corpus callosum, and the aqueductal FL void sign, REFL acting increased CSF velocity through the cerebral aqueduct. The bradykinesia and gait apraxia of NPH may mimic Parkinson's disease, although there is typically no associated tremor. Binswanger's disease, also known as subcortical arteriosclerotic encephalopathy, is a continuous, irreversible ischemic degeneration of periventricular and deep white matter. MRI reveals extensive periventricular and deep white matter hyperintensities, which REFL ECT microinfarctions and demyelination, and enlarged ventricles. Hathout GM, Clinical Neuroradiology, a case-based approach, Cambridge University Press, 2009, p. 106. Osborne AG, Blaise. E. Binswanger's disease. 34. A 34-year-old liver transplant recipient presents to hospital with confusion and seizures. A CT brain reveals low attenuation in the deep and subcortical white matter of the occipital and parietal lobes bilaterally. There is no abnormal enhancement post for contrast administration. As the reporting radiologist, you advise that the clinical team RST. A. Measure blood glucose. B. Measure serum alpha-fetoprotein. C. Measure blood pressure. D. Send coagulation screen. E. Measure D-dimer. Imaging, Brain, A. Mirces, 2004, 2-1, 2427. 34. C. Measure blood pressure. The CT phi endings are consistent with PRES. This is a usually reversible neurological syndrome with a variety of presenting symptoms ranging from altered mental status to seizures, headache, and loss of vision. Common causes include hypertension, eclampsia, and preeclampsia, immunosuppressive medications such as cyclosporin, various antineoplastic agents, including interferon, SLE, and various causes of renal failure. Hypertension is common in PRES, but may be mild and is not universally present, especially in the setting of immunosuppression. However, in the vignette given, hypertension is a possible cause and should be sought. Cyclosporin or central nervous, head and neck answers 271. Tacrolimus might be causes. The former is thought to result in PRES both via direct neurotoxic effect and by causing hypertension. The condition is not always reversible and may result in hemorrhagic infarcts. The classic MRI phi ending is of hyperintensity on flare in the parieto-occipital and posterior frontal cortical and subcortical white matter. Less commonly the brainstem, basal ganglia, and cerebellum are involved. Atypical imaging appearances include contrast enhancement, hemorrhage, and restricted diffusion on MRI. Abnormalities can often be seen on CT, as described in the vignette. McKinney AM, Short J, Trowit CL, McKinney ZJ, Kozak OS, Santa Cruz KS ETAL posterior reversible encephalopathy syndrome. 248 central nervous, head and neck questions. 35. A 34-year-old female presents with neurological symptoms suggestive of MS and is referred for an MRI of brain by the neurology team. Which of the following sequences is most useful for determining if there are plagues of different ages, i.e. dissemination in time? A. Flare. B. T2WI. C. Pre- and post-contrast T1WI. D. Proton density. E. Stir. 36. Phi endings. American Journal of Röntgenology 2007, 189, 904912. 35. C. Pre- and post-contrast T1WI. MS plagues are generally most conspicuous on flare sequences. However, if there are enhancing and non-enhancing plagues on T1WI post-contrast, this indicates plagues of different ages, i.e. dissemination in time. While this is not diagnostic of MS, imaging alone never is, it is very suggestive. Proton density sequences are useful, but not quite as useful as flare sequences, in showing periventricular lesions. T2WI sequences are superior to flare sequences when it comes to detection of lesions in the posterior fossa and spinal cord. T2W stir is probably superior to standard T2WI sequences in detecting spinal cord lesions, but is not routinely used. Stir sequences or fat suppression are useful when imaging the optic nerves, as contrast between lesions and the surrounding orbital fat is increased. Pretorius PM and Quaggabeer G. The role of MRI in the diagnosis of misclinical radiology. E. Stir. 36. A 34-year-old woman presents with a seizure. She has a history of migraine and low mood over the preceding year, and reported occasional episodes of confusion. On examination there is slight left-sided motor weakness. An MRI of brain reveals small multifocal frontal and parietal subcortical white matter. 36b SLE. The combination of white matter hyperintensities and focal infarcts, indicated by the areas of restricted diffusion, in combination with established neurology and neuropsychiatric symptoms in a woman of childbearing age strongly suggests the diagnosis of cerebral lupus. SLE is an autoimmune disorder that affects many organ systems, including the CNS. Clinical presentation can include migraine, seizures, stroke, chorea, psychosis, mood disorder, acute confusional state, cognitive dysfunction, transverse myelopathy, cranial neuropathies, and aseptic meningitis. The CNS pathology includes vasculitis, dural venous sinus thrombosis, cerebritis, intracranial hemorrhage, infarction, and infection. Infarction can occur as a result of direct thrombosis as well as embolism from Liebman Sachs endocarditis. Diffuse neuropsychiatric symptoms are attributed to direct neuronal damage mediated by antibodies. The most common imaging Phi ending is small multifocal T2WI, or flare hyperintense white matter lesions. Focal infarcts and gray matter lesions may also be seen, as well as diffuse steroid-responsive subcortical lesions. Acute lesions may enhance. Mr. Angiography and venography may show thrombotic lesions of vessels and dural venous sinus thrombosis, respectively. When a patient with SLE presents with an acute neurological deterioration, it is crucial to image them promptly, initially with unenhanced CT to exclude hemorrhage, and then with MRI, including post-contrast sequences, to evaluate for stroke or abscess. Note that a negative brain MRI cannot exclude cerebral lupus. Treatment consists of immunosuppression, with anticoagulation for thrombotic events. Stroke is atypical for Ms. small vessel ischemia, should not occur in such a young age without an underlying cause, and is not a satisfactory diagnosis. Sussek syndrome is a triad of encephalopathy, branch retinal artery occlusions, and hearing loss. It is a microangiopathy of unknown etiology. 272 central nervous, head and neck answers. And results in multiple T2WI hyperintense deep white matter and corpus callosum lesions. Lyme disease results in T2WI hyperintense paraventricular white matter lesions, which may enhance, and it may resemble ADEM or Ms. Lalani. Lyme disease. 37, a 73-year-old has been referred for assessment of cognitive decline. A CT brain reveals cerebral atrophy, and a dementia specialist referred. Refers her for PET CT brain. Which of the following Phi endings is most consistent with early Alzheimer's disease? A. Diffuse reduced activity. B. Reduced activity in the precuneus and posterior cingulate gyrus. C. Reduced activity in the frontotemporal regions. Disease results in T2WI hyperintense paraventricular white matter. 37. B. Reduced activity in the precuneus and posterior cingulate gyrus. FDG PET-CT has been shown to have a sensitivity and specificity of 93% for mild to moderate Alzheimer's disease. The technique has been shown to provide important prognostic information so that a negative PET-CT scan is indicative of unlikely progression of cognitive impairment for a mean follow-up of 3 years in those patients who initially present with cognitive symptoms of dementia. The more specified C5 endings on PET-CT in Alzheimer's disease are early reduced activity in the precuneus/posterior cingulate gyrus and the superior, middle, and inferior temporal lobe gyrus, with relative sparing of the primary sensory and visual cortex, and sparing of the striatum, thalamus, and cerebellum. Diffuse reduced activity of the cortical/subcortical regions and cerebellum is more typical of multi-infarct dementia. Reduced activity in the frontotemporal regions is more consistent with frontotemporal dementia. Reduced activity in the occipital cortex REFLX the visual problems encountered in Lewy body dementia. Reduced activity in the caudate and lentiform nuclei is more typical of Huntington's chorea. Silverman DHS and Thompson PM, structural and functional neuroimaging. E. Reduced activity bilaterally in the occipital cortex. 38. A 15-year-old male presents with a history of recurrent epistaxis and nasal obstruction. MRI demonstrates a lesion centered at the sphenopalatine foramen, which is hypointense on T1WI and heterogeneously intermediate signal on T2WI. Intense lesional enhancement and multiple FL voids are noted on postgadolinium T1WI. What is the diagnosis? A. Ludwig angina. B. Nasopharyngeal carcinoma. C. Inverted papilloma. D. Juvenile angiofibroma. E. Glomus jugulare. Central nervous, head and neck questions 249. 30. 38. D. Juvenile angiofibroma. Juvenile angiofibromas are benign but locally aggressive tumors with high vascularity. They typically occur in adolescent boys and present with recurrent epistaxis and nasal obstruction. They are centered within the sphenopalatine foramen and involve the pterygopalatine fossa, producing a bowed appearance of the posterior wall of maxillary sinus and widening of pterygopalatine fossa, inferior orbital, and periogomaxillary fissures. Osseous erosion is commonly seen. The specified differentiating feature on MRI is the presence of multiple FL voids on T2WI and enhanced T1WI. Momeni A., Robert C., and Chu F., Imaging of Chronic and Exotic Sinonasal Disease, Self-Assessment Module. American Journal of Röntgenology 2007, 189, S46, S48. Ludwig B., Foster B., Sato N., Nadger RN, Castro Aragon I., and Sakai O., Diagnostic Imaging in Non-Traumatic Pediatric Head and Neck Emergencies. Radiographics 2010, 30, 781, 799. 39. B. Inverted papilloma. Inverted papilloma. 39. A 50-year-old male presents with a history of intermittent epistaxis, nasal obstruction, and frontal headache. He undergoes a CT of the sinuses that demonstrates an isodense soft tissue mass filing the right maxillary antrum with extension through the infundibulum into the nasal cavity. There is associated bony remodeling of the infundibulum. On MRI, the mass is isointense to muscle on T1WI and T2WI, and demonstrates a convoluted cerebriform pattern on enhanced T1WI. The remainder of the sinuses are unremarkable. What is the diagnosis? A. Juvenile angiofibroma. B. Inverted papilloma. C. Anthracoanal polyp. D. Invasive fungal sinusitis. E. Nasal carcinoma. 40. A 45-year-old female patient presents with recurrent frontal sinusitis following functional non-traumatic pediatric head and neck emergencies. Radiographics 2010, 30, 781, 799. 39. B. Inverted papilloma. Inverted papillomas are uncommon benign epithelial neoplasms with significant malignant potential. They arise from the lateral nasal wall or maxillary sinus. They are most commonly seen in 40-70-year-olds with a male-to-female ratio of 2:1. CT demonstrates a soft tissue mass centered in the middle meatus associated with bone remodeling. Stippled calcified cation is seen in 20% of cases. On MRI, it is isointense on T1WI and ISO/hypointense on T2WI. Heterogeneous enhancement is seen in 50% of cases. A convoluted cerebriform pattern on T2WI or enhanced T1WI is typical of inverted papillomas. Juvenile angiofibromas are seen in younger patients and are located in the posterior nasal cavity. They demonstrate intense enhancement and FL voids on MRI. Anthracoanal. Central nervous, head and neck answers 273. Polyps are homogeneously hyperintense on T2WI. Invasive fungal sinusitis is primarily seen in immunosuppressed patients. They are frequently bilateral. CT-Phi endings include complete opacified cation of sinuses by hyperdense mass, erosion or remodeling of sinuses, and intrasinus calcified cation. Cation. They are hypointense on T2WI. Nasal carcinomas cause bone erosion/destruction rather than remodeling. Momeni A., Robert C., and endoscopic sinus surgery, FES. Which of the following CT-Phi endings is not commonly associated with postoperative frontal recess stenosis? A. Inadequate removal of the adger nasi and frontal recess cells. B. Retained superior portion of the uncinate process. C. Medialization of middle turbinate. D. Osteoneogenesis due to chronic INFL amation or mucosal stripping. E. Scarring or INFL amatory mucosal thickening. Assessment Module. American Journal of Röntgenology 2007, 189, S46, S48. 40. C. Medialization of middle turbinate. FES is the treatment of choice for patients with medically refractory sinusitis. Obstruction of the frontal recess is the main cause for medically refractory frontal sinusitis. The frontal recess is considered a difficult area to treat with FES, and it is also prone to restenosis. All of the above options are commonly associated with postoperative frontal recess stenosis except medialization of middle turbinate. Medialization, bulgarization, is performed to treat a lateralized middle turbinate, which is a well-recognized cause of frontal recess stenosis. Huang B., Lloyd K., Delgaudio J.M., Jablonski E., and Hudgens Pa. Failed endoscopic sinus surgery, spectrum of CT phi endings in the frontal recess. Radiographics 2009, 29, 177-195. 41. 41. A 12-year-old male with a history of gelastic seizures is referred for MRI of the brain. Which of the following statements regarding hematomas of the tuber cinereum is true? A. No change in size, shape, or signal intensity on follow-up MRI. B. Demonstrate homogeneous contrast enhancement. C. Calcified cation is a common phi ending. D. Hyperintense on T1WI and T2WI, and hypointense on fat-suppressed sequences. E. Located in the sella turcica. 42. 41. A. No change in size, shape, or signal intensity on follow-up MRI. Hypothalamic hematomas are developmental malformations located in the tuber cinereum of the hypothalamus. The typical patient is male. Male in the phi RST or second decade of life, presenting with precocious puberty or gelastic seizures. On MRI, they appear as well-defined NED pedunculated or sessile lesions that are ISO/mildly hypointense on T1WI and ISO/hyperintense on T2WI, with no contrast enhancement or calcified cation. Lack of interval change strongly supports the diagnosis. Salim S., Ahmed Hesham MS, and Lee D.H. Lesions of the hypothalamus, MR imaging diagnostic features. Radiographics 2007, 27, 1807-1108. 42, B2. 42. You are reporting a CT scan of neck in a patient with a head and neck cancer. You see an enlarged necrotic jugulogastric lymph node on the right side and wish to describe the appropriate level of this lymph node in your report. What is the correct level? A. I. B. 2. C. 3. 2. Lymph nodes in the neck have been divided into 7 levels, generally for the purpose of squamous cell carcinoma staging. This is, however, not all-inclusive, as the parotid nodes and retropharyngeal space nodes are not included in this system. Level I, below mylohyoid to hyoid bone anteriorly level IA, submental level IB, submandibular level 2, jugulogastric, base of skull to hyoid, level 3, deep cervical, hyoid to cricoid, level 4, cricoid to clavicle, level V, posterior triangle groups level VA, accessory spinal, posterior triangle, superior half level VB, accessory spinal, posterior triangle, inferior half level 6, prelaryngeal/pretracheal/delphian node level 7, superior mediastinal, between. Common carotid arteries, CCAs, below top of manubrium, lymph node levels of the (250 central nervous, head and neck questions). Questions. Questions. 43. A 4-week-old infant with a history of breech delivery is brought to the A&E department with a history of swelling in the left side of the neck and torticollis. An ultrasound of the neck demonstrates a non-tender, focal fusiform enlargement of the lower half of the left sternocleidomastoid muscle. No other abnormality is identified. Ed. What is the diagnosis? A. Fibromatosis coli. B. Lymphoma. C. Rhabdomyosarcoma. D. Cystic hygroma. E. Branchial cleft cyst. 44. A 60-year-old female presents with a history of 43. A. Fibromatosis coli. Fibromatosis coli or pseudotumor of the sternocleidomastoid muscle is a benign self-limiting condition that occurs in the FIRST 2 for weeks of life. It is often associated with breech or forceps delivery. It is thought to result from pressure necrosis and subsequent fibrocollagenous infiltration of the sternocleidomastoid muscle. Typical presentation is with a FIRM and non-tender mass in the lower 2/3 of the sternocleidomastoid muscle. It may be associated with torticollis in approximately 20% of cases. It usually resolves spontaneously in the FIRST year of life. Typical FI endings on ultrasound include focal or diffuse enlargement of the sternocleidomastoid with variable facial pain and diplopia. Clinical examination reveals palsies of the 3, 4, and 6 cranial nerves, Horner's syndrome, and facial sensory loss in the distribution of the ophthalmic and maxillary divisions of the trigeminal V cranial nerve. Where is the causative abnormality located? A. Dorello's canal. B. Cavernous sinus. C. Superior orbital fissure. D. Inferior orbital fissure. E. Meckel's cave. Ludwig B. Foster B. Sato N. Nadger R. 44. B. Cavernous sinus. Cranial nerves 3, 4, and 6 and ophthalmic V1 and maxillary V2 divisions of the V cranial nerve course through the cavernous sinus along with the internal carotid artery. The V2 division of the trigeminal nerve passes through the inferior portion of the cavernous sinus and exits via the foramen rotundum. The remainder of the cranial nerves mentioned above enter the orbit via the superior orbital fissure. The cavernous sinus location accounts for these features. Palsies of cranial nerves 3, 4, and 6 result in ophthalmoplegia. Involvement of V1 and V2 divisions of the trigeminal nerve produces facial pain and sensory loss. Involvement of sympathetic nerves around the internal carotid artery results in Horner's syndrome. This cluster of phi endings is found in Tolosa-Hunt syndrome, an idiopathic inflammatory process involving the cavernous sinus. Huang J., Eastwood J., and Glastonbury C. What's in a name? Eponyms in head and neck imaging. Clinical Radiology 2010, 65, 237. E. Meckel's cave. 45. A 50-year-old male undergoes an Mr. carotid angiogram on which an incidental soft tissue mass is noted in right parapharyngeal soft tissue. The mass displaces the right parapharyngeal space anteromedially. What is the location of the soft tissue mass? A. Masticator space. E. Parotid space. Loss of symmetry and displacement of the parapharyngeal space are useful for lesion identify cation and localization in the parapharyngeal soft tissues. A thorough knowledge of the anatomical relationship between the spaces is essential. The parapharyngeal space is shaped like an inverted pyramid with the apex pointing inferiorly toward the greater cornu of the hyoid bone, and the skull base demarcates the base superiorly. A lesion arising from the parotid space displaces the fat in the parapharyngeal space anteromedially. A lesion in the masticator space displaces the parapharyngeal fat posteromedially. Carotid space lesions displace it anteriorly, mucosal space lesions displace it posterolaterally, and retropharyngeal space lesions displace it anterolaterally. Posterior displacement of the carotid space or parapharyngeal fat completely surrounding a lesion localizes it to the parapharyngeal space. Barmy S and Yim C. Blind spots at E. Parotid space. 46. A 55-year-old man undergoes 9/9 MTC scintigraphy, on which incidental note is made of multiple foci of increased tracer uptake in the parotid regions. Ultrasound of the parotid glands demonstrates bilateral multiple hypoechoic lesions with anechoic areas. On MRI, the lesions are of intermediate signal intensity on T1WI and intermediate signal intensity with focal areas of hyperintensity on T2WI. There is no enhancement following contrast administration. What is the likely diagnosis? A. Pleomorphic adenomas. B. Warthin tumors. C. Lipomas. D. Hemangiomas. E. Barmy S and Yim C. Blind spots at brain imaging. Radiographics 2009, 29, 1877-1896. 46. B. Warthin tumors. Warthin tumor or adenolymphoma is the second most common benign tumor of the parotid gland. It is usually solitary. Multiple or bilateral parotid masses and increased uptake on 9/9 MTC are strongly suggestive of Warthin tumor. Warthin tumors do not enhance following gadolinium administration. Pleomorphic adenomas are usually solitary and unilateral. They appear as hypoechoic, lobulated, well-defined lesions with posterior acoustic enhancement on ultrasound scan USS. Central nervous, head and neck answers 275. On MRI, they are of intermediate signal on T1WI, and hyperintense on T2WI. They demonstrate homogeneous enhancement following gadolinium administration. Mucoepidermoid carcinomas vary in appearances. Low-grade tumors are similar to pleomorphic adenomas. High-grade tumors are heterogeneous with low to intermediate signal intensity on T1WI and T2WI. They demonstrate infiltrating margins and heterogeneous enhancement following gadolinium administration. Solar R. Bardula A. Requejo I. Rodriguez E. Ray J. L. and Sankristan F. Pictorial Review, MR Imaging of Carotid Tumors. Clinical Radiology 1997, 52, 269-275. Central nervous, head and neck questions 251. 47. A 60-year-old woman presents with a painless, slowly growing mass in the lateral aspect of the neck. The patient is referred for imaging with a clinical diagnosis of carotid body paraganglioma. Which of the following is a distinctive feature of carotid body paraganglioma on imaging? A. Soft tissue mass in the carotid space. B. Intense enhancement after for contrast administration. C. High signal on T2WI. D. Splaying of the internal and external carotid arteries. E. 26, 745, 763. 47. D. Splaying of the internal and external carotid arteries. Carotid body tumor or paraganglioma is the most common paraganglioma of the head and neck. It arises from the paraganglionic cells located on the medial aspect of the carotid bifurcation. On MRI, they are of low to intermediate signal intensity on T1WI and hyperintense on T2WI. They are hypervascular and demonstrate intense enhancement after contrast administration. Splaying of the internal and external carotid arteries and multiple FL alvoids producing a salt and pepper appearance are distinctive features on imaging. Lee KY, OYW, No HJ, Lee YJ, Young HS, and Kong EY. Extraadrenal paragangliomas of the body, imaging features. American Journal of Röntgenology 2006, 187, for 92504. 48. D. Eccentrically placed lesion in the cord. Table 6.2 illustrates the D. Splaying of the internal and external carotid arteries. E. Low signal on T2WI. 48. A 22-year-old woman presents with upper and lower limb neurological symptoms and signs. She is subsequently discovered on MRI to have a mass in the cervical spinal cord. Which of the following features on MRI is going to point more towards a diagnosis of spinal cord astrocytoma, rather than ependymoma? A. Predominant T2WI high signal. B. Homogeneous enhancement post-gadolinium. C. Short segment of cord involvement. D. Eccentrically placed lesion in the cord. Astrocytoma and ependymoma. Table 6.2 Diagnostic features of astrocytoma and ependymoma. Astrocytoma ependymoma H children adults region C, T, LC, T equals L location in cord eccentric central margins infiltrating sharp other phi endings long segment involve peripheral low T2WI signal associated syndrome neurofibromatosis, 1 neurofibromatosis 2. Smith J.K. D. Eccentrically placed lesion in the cord. E. Sharply marginate lesion. 49. A 52-year-old woman presents with gradually increasing gait disturbance and lower limb sensory symptoms. An MRI of her spine is performed and this shows an anteriorly placed intradural but extramedullary spinal mass. It is fairly markedly low signal on T1WI and T2WI and shows only minimal patchy enhancement post-administration of intravenous gadolinium. What is the most likely diagnosis? A. Neurofibroma. B. Schwannoma. C. Lymphoma. D. Metastasis. E. Meningioma. Röntgenology 2006, 41, 274-293. 49. E. Meningioma. Spinal meningiomas are typically ISO to hypointense on T1WI and slightly hyperintense on T2WI. There is usually strong and homogeneous enhancement with gadolinium. However, some meningiomas may contain calcified cation and are typically the only intradural extramedullary tumors to do so. Some meningiomas can be heavily calcified, and such a meningioma is being described in the question. These will remain dark on all MRI sequences and demonstrate only little contrast uptake in the non-calcified areas. Schwannomas, neurofibromas, and metastases would not typically be hypointense on T2WI. Meningeal lymphomas are very rare and usually manifest as diffuse thickening of nerve roots and / or multiple enhancing nodules. Abul Qasim K. E. Meningioma. 50. You are asked to protocol an MRI scan that is specified Cali being performed to look for vertebral metastatic disease. The radiographer complains that you have asked for too many sequences. Which of the following sagittal sequences is likely to be least helpful for the purposes of your examination? A. Stir. B. T2 fast SE with fat saturation. C. T2 fast SE. D. T1 fast 276 central nervous, head and neck answers. 50. C. T2 fast SE. T2 fast SE is probably the least useful sequence when specified Cali looking for vertebral marrow deposits because the metastases are less conspicuous, typically being high signal on a background of high signal fatty marrow. On Stir and T2 fast SE with fat saturation, the metastases typically stand out as being of increased signal on a background of dark marrow because of the fat saturation techniques. 252 central nervous, head and neck questions. 51. A 44-year-old woman presents with severe facial injuries following an RTA. CT of the facial bones demonstrates multiple maxillofacial fractures in keeping with the LE fort configuration. Which of the following statements regarding LE fort fractures is false? A. Any combination of LE fort I2 and 3 fractures can occur. B. Disruption of pterygoid plates from the posterior maxilla is an essential phi ending in LE fort fractures. C. LE fort fractures by definition refer to fractures involving the maxilla bilaterally. D. Craniofacial separation is noted in LE fort 3 pattern. E. LE fort fracture associated with a palate fracture will result in widening of the maxillary arch. Or other lesions will clearly stand out. Van de them JWM, Van den Howie. Tumors. European Journal of Radiology 2004, 50, 159-176. 51. C. LE fort fractures by definition refer to fractures involving the maxilla bilaterally. Separation of all or a portion of the maxilla Maxilla from the skull base is described as a LE-Fort fracture. This can be unilateral when it is associated with sagittal or parasagittal fractures of the palate. LE-Fort fractures by definition involve the posterior maxillary buttress at the junction of the posterior maxillary sinus and the pterygoid plates of the sphenoid. This may be either through the pterygoid plates or through the posterior walls of the maxillary sinus. Once a pterygomaxillary disruption has been identified, the remaining facial buttresses are inspected to identify the type of LE-Fort fracture. In LE-Forti fracture, the maxillary arch will move in relation to the rest of the face and skull. In LE-Fort2 fracture, the entire maxilla will move in relation to the skull base. In LE-Fort3, there is complete craniofacial separation. Any combination of LE-Fort-I2 and 3 can occur. Posterior extension of LE-Fort fracture into the hard palate results in widening of the maxillary arch and dental malocclusion. 52. A 25-year-old woman is brought to the A&E department following an RTA. CT of brain and facial bones are requested for assessment of head and facial injuries. On the CT studies, incidental note is made of dense calcified cation of the falx cerebri, midface hypoplasia, and prognatism. Multiple cystic lesions are also noted in the mandible, which are associated with cortical expansion. Some of the lesions break through the cortex. Following contrast administration, there is minimal peripheral enhancement. What is the underlying mandibular abnormality? A. Radicular cyst. B. Keratocystic odontogenic tumor. C. Dentigerous cyst. D. Staphon cyst. E. Amyloblastoma. Hopper R.A., Sulam E.S., and Shear W. Diagnosis of midface. Radiographics 2006, 26, 783-793. 52. B. Keratocystic odontogenic tumor. These are benign but locally aggressive developmental tumors affecting adults in the 2nd to 4th decades. They are most commonly located in the mandibular ramus and body, and are associated with an impacted tooth. They may be unilocular or multilocular, and often contain daughter cysts extending into the surrounding bone. They can be associated with cortical expansion and erosion. They demonstrate minimal peripheral enhancement with contrast. The presence of multiple keratocystic odontogenic tumors raises the possibility of Borland basal cell nevus syndrome, which is an autosomal dominant disorder. Associated features include multiple basal cell carcinomas of the skin, mental retardation, midface hypoplasia, frontal bossing and prognatism, calcified cation of the falx and dura, and bifida ribs. Devanika Kirby, Subramaniam RM, Red D. A 45-year-old female undergoes an MRI of the pituitary that demonstrates a kidney-shaped lesion located centrally in the pituitary fossa in the axial plane. It is hyperintense on T1WI and hypointense on T2WI. There is no enhancement following gadolinium administration, and no FLUID level. What is the diagnosis? A. Raft cleft cyst. B. Craniopharyngioma. C. Cholesterol granuloma. D. Hemorrhagic adenoma. E. Lipoma. Central nervous, head and neck questions 253. 54. A 30-year-old male presents with a fluid uxuent swelling in the right side of the neck. On ultrasound examination, an anechoic lesion with posterior acoustic enhancement is noted along the anteromedial margin of the sternocleidomastoid muscle, posterior to the submandibular gland and superficial to the carotid artery and internal jugular vein. There is no increased surrounding vascularity on power Doppler. What is the likely diagnosis? Central nervous, head and neck answers 277. 53. A. Raft cleft cyst. These are benign cystic lesions of the pituitary fossa derived from the Raft pouch. They are usually asymptomatic. Raft cleft cysts are located in the midline between the anterior and posterior pituitary lobes and have a characteristic kidney shape on axial images. They are homogeneously hyperintense on T1WI due to high protein concentration and hypointense on T2WI due to low intracystic water content. They do not enhance following contrast administration. Absence of a fluid UID FLUID level is helpful in differentiating Raft cleft cyst from hemorrhagic adenoma. Acute hemorrhage has heterogeneous signal on T2WI and may demonstrate thin peripheral enhancement on T1WI. Craniopharyngiomas have variable solid, cystic, and calcified egg components. They demonstrate heterogeneous enhancement following contrast. They may be intracellular or supracellular. A pseudo FLUID level may occasionally be seen in craniopharyngioma. Lipoma and cholesterol granuloma are hyperintense on both T1WI and T2WI. Bonneville F, Catton F, Marsat K, Dormont D, Bonneville JF, and Chiris J, T1 signal hyperintensity in the cellar region, spectrum of phi endings. Radiographics 2006, 26, 93 113. 54. E. Second branchial cleft cyst. The majority of branchial cleft anomalies arise from the second branchial cleft. The described phi endings are typical of a second branchial cleft cyst. Similar ultrasound appearances may be seen in a phi RST branchial cleft cyst or a dermoid cyst. The anatomical location is the key to the diagnosis. Dermoid cysts are typically midline in location in the neck, and phi RST branchial cleft cysts are located in the region of parotid gland, external auditory canal, and angle of mandible. Lymphangiomas are typically located in the posterior triangle. On ultrasound, they appear multiloculated with intervening thin septa. Abscesses appear as ill-defined, irregular collections with thick walls and internal debris. Surrounding soft tissue edema, hyperemia, and enlarged adjacent lymph nodes are also noted. Wong KT, Lee YYP, King AD, and Ahujaat. Imaging of cystic and cyst. A. Dermoid cyst. B. Lymphangioma. C. First branchial cleft cyst. A. Dermoid cyst. B. Lymphangioma. C. Referred for MRI of the neck. Which of the following features on MRI is useful in differentiating retropharyngeal abscess from retropharyngeal suppurative lymph node? 55. D. Filling of retropharyngeal space from side to side. Understanding the retropharyngeal space anatomy is crucial in differentiating retropharyngeal space abscess and retropharyngeal suppurative lymph node. The retropharyngeal space is bounded by visceral fascia covering the pharynx and esophagus anteriorly, the prevertebral fascia covering the prevertebral muscles posteriorly, and the carotid sheaths laterally. A retropharyngeal suppurative lymph node is unilateral, whereas a retropharyngeal abscess, phi LLS the entire retropharyngeal space from side to side. The differentiation is important because many cases of suppurative lymph nodes do not have purulent material at surgery. The treatment for suppurative lymph nodes is a trial of antibiotics if the patient is stable. Surgical drainage is considered if there is progression, or if the suppurative lymph node is large at presentation. The volume of central low density is a better predictor of purulence than the mere presence of rim enhancement and low density center. Huang J.K., Brandstetter for B.F., Eastwood J.D. 278 central nervous, head and neck answers. A. Enhancing wall. B. Rounded or ovoid. Is increased T2WI/flare signal in the cortex adjacent to this area of meningeal disease. There is also thickening and enhancement noted of the right trigeminal and facial nerves on post-contrast T1WI. Further enhancement is also noted. 56. B. Neurosarcoid. Whilst primary neurosarcoid is rare, it is not uncommon for the systemic disease to present via its neurological manifestations. The phi endings of neurosarcoid are non-specified C, with the common manifestations mirroring those described in this patient. Leptomeningeal thickening and enhancement are classical. Involvement of the perivascular spaces adjacent to this can cause increased signal in the adjacent cortex. This appearance can mimic meningioma. Multifocal meningiomas and nerve sheath schwannomas are features of NF2, but this would not be expected to resolve with steroid therapy. The features described are 57. A 62-year-old man presents with tremor and incontinence. Examination reveals bradykinesia and gait ataxia. He is also noted to have a reduced mini-mental state examination, MMSE, and postural hypotension. He has an MRI scan of brain as part of the diagnostic workup. On the axial T2WI, a cruciform hyperintensity in the pons is noted. Which of the following is the most likely diagnosis? A. Parkinson's disease. B. Multisystem atrophy, MSA. C. Progressive supranuclear. Seminars in Röntgenology 2004, 39, 4495504. 57. B. Multisystem atrophy, MSA. T2WI cruciform hyperintensity, or the hot cross bun sign within the pons. Pons is suggestive of MSA, although it does not specify C, as it also occurs in spinocerebellar ataxia. Other MRI 58. A 56-year-old features include hyperintensity within the putamen. Patients with MSA typically have Parkinsonian features poorly responsive to levodopa therapy and autonomic disturbance. MRI features of Parkinson's disease are generally non-specified C, but narrowing of the pars compacta of the substantia nigra may be seen on T2WI. Substantia nigra atrophy is also a feature of Lewy body dementia. T2WI hypointensity of the putamen due to iron deposition is a feature of progressive supranuclear palsy. Gilman S., Wenning G.K., Low Pa, Brooks D.J., Matthias C.J., and Trojanowski J.K. 56-year-old man with chronic alcohol dependence presents with progressive cognitive impairment, gait disturbance, and signs of interhemispheric disconnection. An MRI scan of brain demonstrates increased T2WI signal lesions without mass effect within the corpus callosum and dorsal part of the external capsule. Which of the following is the most likely diagnosis? A. Wernicke's encephalopathy. B. Osmotic myelinolysis. C. Markey-Favre-Bignami disease. D. Alcohol withdrawal syndrome. 58. C. Markey-Favre-Bignami disease. This is a rare complication of chronic alcohol consumption characterized by demyelination and necrosis of the corpus callosum, although other white matter tracts, such as the external capsule, may be involved. Bilateral and symmetrical T2WI hyperintensities within the thalami, periaqueductal gray, and mammillary bodies are seen in Wernicke's encephalopathy. Osmotic myelinolysis is usually secondary to rapid changes in serum sodium and results in increased T2WI signal within the central pons. Extrapontine myelinolysis is rare. In alcohol withdrawal syndrome, patients present with seizures and delirium tremens. MRI may show volume loss in the temporal cortex and anterior hippocampus. Hepatic encephalopathy secondary to hepatocellular failure may produce T1WI hyperintensity within the caudate nucleus, globus pallidus, putamen, and anterior midbrain due to increased concentration of manganese. 59. A. Decreased CBF/decreased CBV/increased. 59. A 74-year-old woman is admitted with acute left-sided hemiplegia of 2 hours onset. On assessment by the stroke team, she is deemed suitable for thrombolysis and referred for CT. As part of your institution's workup, CT perfusion, CTP, is performed following the unenhanced study. Which of the following CTP phi endings with regards to cerebral blood FLL, CBF, cerebral blood volume, CBV, and mean transit time, MTT, are consistent with infarction? A. Decreased CBF/decreased CBV/increased MTT. Increased MTT. In identifying the ischemic penumbra, CT perfusion offers promise in improved patient selection for thrombolysis beyond a rigid time window. In the infarct core, tissue which is not salvageable, both CBF and CBV are decreased with a course. Corresponding increase in MTT. Penumbral tissue, which is potentially recoverable by thrombolysis, exhibits a CBF/CBV mismatch with an increased CBV, but decreased CBF and increased MTT. An increase in CBF and CBV with decreased MTT is a feature noticed in tumors secondary. Central nervous, head and neck questions 255. 60. An immunocompetent 24-year-old patient presents with an secondary to angiogenesis and microvascular permeability. Acute history of right-sided limb weakness, which has rapidly progressed. The patient now also has mixed sensory symptoms and poorly controlled seizures. Basic observations and initial blood results are normal. An MRI is carried out which shows a large mass-like lesion in the right posterior frontal lobe. There is mild mass effect associated with this lesion on the adjacent parenchyma, with mild compression of the right lateral ventricle. The lesion is also noted to involve the corpus callosum and cross the midline into the left cerebral hemisphere. This lesion is bright on FLAIR imaging. On post-contrast T1WI, the lesion has peripheral rim enhancement. Vascular structures are noted to pass through the lesion. There is no evidence of necrosis or hemorrhage. On DWI, the B1000 sequence reveals increased signal in the lesion. Other high T2WI lesions are noted in the cerebellum, with a further lesion in the spinal cord. What is the most likely diagnosis? Based on this information. A. Ms. B. Glioblastoma multiforme. C. High-grade astrocytoma. D. Lymphoma. E. Abscess. 61. A 32. 60. A. Ms. The key feature in this clinical vignette is the identify cation of the mass lesion crossing the midline. Only a few lesions demonstrate this ability, and they are GBM, lymphoma, metastases, MS, and other white matter disorders, lipoma, stroke, and shearing injuries. Abscess is thus excluded and would be unlikely given the clinical features. GBM is unlikely given the absence of necrosis and would be rare in a patient of this age group. High-grade astrocytomas do not involve the corpus callosum and cross the midline. Lymphoma exhibiting these features would be uncommon in immunocompetent patients, being more typically associated with HIV-related lymphoma. Tomofactive MS typically presents with an acute clinical history and frequently displays the imaging features described. The presence of vascular structures crossing the lesion also indicates this diagnosis, as these would be displaced by neoplastic lesions. Following a headache. She is referred for CT querying venous thrombosis. Unenhanced CT brain demonstrates bilateral low attenuation change within the thalami. Given this location, where is the most likely site of thrombosis? A. Superior sagittal sinus. B. Transverse sinus. C. Sigmoid sinus. D. Straight sinus. 153-155. 61. D. Straight sinus. Pregnancy is a risk factor for both venous sinus thrombosis and hypertensive hemorrhage secondary to eclampsia. Hyperattenuating thrombus within the occluded. E. Cavernous sinus. 62. A 36-year-old man is admitted following a seizure. Unenhanced CT demonstrates a right frontal mixed attenuation lesion, which avidly enhances post-contrast. Multiple FLL voids are seen on MRI of brain. What phi ending on catheter angiography differentiates arteriovenous malformation, AVM, from other vascular lesions of the brain? A. Early venous drainage. B. Arterial stenoses of feeder vessels. 62. A. Early venous drainage. Brain AVMs are abnormal connections between arteries that would 62. A. Early venous drainage. Brain AVMs are abnormal connections between arteries that would normally supply the brain tissue and veins that normally drain the brain, resulting in shunting with an intervening network of vessels within the brain parenchyma. The phi ending of early venous drainage is important in differentiating brain AVMs from other vascular lesions. Cortical venous drainage may be seen in superphyseal lesions. Recruitment of transdural supply is observed in large lesions, although this is a more typical feature of proliferative angiopathy, which is a diffuse type of AVM. Classically, in this condition, normal brain parenchyma is interspersed between the abnormal vessels. Stenoses of feeder vessels are also often identified in proliferative angiopathy. The caput medusa of dilated medullary veins is a feature of DVAs, a normal variant. Dilated cortical veins are arteriovenous fistulas, DAVFs, which are abnormal connections between arteries that normally supply the meninges, but not the brain, and small venules within the dura. J. S. Pong. 63. 256 central nervous, head and neck questions. 63. You are contacted by the A&E department requesting a CT brain for a 28-year-old female presenting with headache which reached peak intensity 15 minutes after onset. The headache came on during sexual activity and is associated. E. Association with vomiting. 64. A 54-year-old female is admitted following a seizure. CT of the brain demonstrates a rounded, 2 cm hyperdense lesion within the right temporal lobe, which exhibits calcified cation. No enhancement is seen post-contrast. On follow-up MRI of brain, the lesion is of mixed intensity on T1WI. The lesion has a hypointense rim on T2WI. Prominent susceptibility effect is noted on T2*G imaging. DWI is normal and no enhancement is demonstrated on T1WI post-gadolinium. Based on the imaging phi endings, what is the most likely diagnosis? A. AVM. B. Hemorrhagic neoplasm. C. Cavernous malformation, cavernoma. D. Amyloid angiopathy. E. Capillary telangiectasia. 64. C. Cavernous malformation, cavernoma. This is a benign vascular hematoma, which can occur anywhere throughout the CNS, although spinal cord involvement is rare. It is typically a discrete E. Capillary telangiectasia. Discrete, lobulated mass, 4 centimeters containing blood products at different stages of evolution. On MRI they are described as having a popcorn appearance of mixed signal intensity with a hypointense hemosiderin rim. They display little to no enhancement. Prominent susceptibility effect on T2*G is typical. AVMs will demonstrate multiple FL voids. Hemorrhagic neoplasms will exhibit strong enhancement and an incomplete hemosiderin rim. Multiple black dots are a feature of amyloid angiopathy. Capillary telangiectasias are poorly demarcated lesions, usually 1 centimeter, demonstrating brush-like enhancement on T1WI post-contrast. They are not usually identified on CT. Osborne AG, Lacer SI, Salzman K. E. Capillary telangiectasia. 65. A 42-year-old man is admitted with sudden onset headache suspicious of subarachnoid hemorrhage. There is no loss of consciousness. Unenhanced CT demonstrates blood in the cisterns around the midbrain and into the anterior part of the interhemispheric fissure. Subsequent CT angiogram, CTA, is negative. What is advised next for this patient? A. Lumbar puncture. B. MRA. 65. C. Catheter angiography. Perimesencephalic hemorrhage is confined to the cisterns around the midbrain. In some cases the only blood extra diagnostic yield. However, E. No further investigation necessary. Perimesencephalic hemorrhage. 66. A 74-year-old man with a history of diabetes presents with a history of slurred speech and right-sided weakness, which spontaneously resolved over 1-2 hours. Initial unenhanced CT is normal. Further investigation by MRI is requested. What sequence is most sensitive for diagnosing acute ischemia? The sensitivity and specificity of DWI in detecting acute ischemia are 88-100% and 86-100%, respectively, and DWI is established as better than other conventional MRI techniques. In addition, acute from chronic ischemia can be differentiated. Central nervous, head and neck questions 257. 67. A 16-year-old female is referred for MRI after presenting with an increasing number of cutaneous neurofibromata. As a child she had been noted to have a café au lait spot on her back. What MRI phi ending would confi RM the diagnosis of NF1? Diagnosis of NF, 1 requires 2 or more of the following: 6 or more café-less spots, 2 or more neurofibromas, or 1 plexiform neurofibroma, axillary/inguinal freckling, optic nerve glioma, sphenoid vein dysplasia, or a phi RST degree relative with NF1. The classic imaging appearance is multiple focal areas of white matter and deep gray matter signal abnormality. Other potential phi endings include intracranial stenoses and moya-moya-type proliferation. NF2 characteristically presents with multiple intracranial schwannoma. A. Multiple hyperintense white matter foci on T2WI. B. 68, a 16-year-old male with a history of epilepsy is investigated via MRI. Axial T2WI demonstrates a cystic space within the left frontal lobe isointense to CSF. This is causing local mass effect, and there is adjacent enlargement of the left lateral ventricle. What is the most likely diagnosis? A. Porencephalic cyst. B. Arachnoid cyst. C. Schizencephaly. D. Hydranencephaly. E. Ependymal cyst. 69, a 32-year-old man presents with schizophrenic-like psychosis and Parkinsonian-type movement disorder. There is a family history of neuropsychiatric disturbance. An initial CT is requested which demonstrates heavy bilateral, symmetric calcified cations within the globus pallidus, thalami, putamen, and cerebellum. There is no enhancement post-contrast. Which of the following suggests a diagnosis of Fahrenheit disease over pseudohypoparathyroidism? Poencephaly is a congenital/acquired cystic cavity within the brain parenchyma with adjacent enlargement of the lateral ventricle. They develop in utero or early infancy. Arachnoid cysts are also CSF isointense. 69. Normal calcium phosphorus metabolism. Fahrenheit disease is a rare degenerative neurological disorder characterized by extensive bilateral basal ganglia calcified cations that can lead to progressive dystonia, Parkinsonism, and neuropsychiatric manifestations. CT has higher diagnostic specificity for basal ganglia calcified cation over MRI. The distribution of calcified cations is similar in endocrinological disorders such as hyperparathyroidism, hypoparathyroidism, and pseudohypoparathyroidism. The calcium phosphorus metabolism is usually normal in Fahrenheit disease. In pseudohypoparathyroidism, the serum calcium is low with an appropriately high parathyroid hormone PTH due to PTH resistance. Osborne AG. A. Involvement of the globus pallidus. B. Involvement of the thalami. C. Involvement of the putamen. D. Involvement of the cerebellum. E. Normal calcium phosphorus metabolism. B. Hypertensive. Hypertensive. MRI demonstrates bilateral parieto-occipital T2WI hyperintense cortical and subcortical lesions. ADC is elevated. Similar lesions are noted in the anterior watershed. This is a disorder of cerebrovascular autoregulation and is associated with eclampsia, which is defined clinically as seizure or coma with pregnancy-induced hypertension. There is a predilection for the posterior circulation and watershed zones, possibly due to its sparse vasomotor sympathetic innervation. T2WI hyperintense lesions within the posterior cortex and subcortical white matter without diffusion restriction are typical. Diffusion restriction/low ADC will be 282 cm. (258 central nervous, head and neck questions). 71, a 62-year-old man is referred for MRI of brain after presenting with cognitive decline, gait apraxia, and urinary incontinence. There is a preceding history of chronic headache. Ventriculomegaly is noted on initial CT. Which of the following conventional MRI phi endings distinguishes aqueductal stenosis from normal pressure hydrocephalus? 71, D, funnel-shaped aqueduct. Aqueductal stenosis is a focal reduction. D. Funnel-shaped aqueduct. E. Relatively normal caliber fourth ventricle. 72. A 24-year-old male boxer is admitted with concussion following a head injury. His admission CT does not demonstrate any evidence of intracranial injury, but the A&E physician asks you about a midline CSF space. You explain that this is a cavum velum interpositum. What distinguishes the CSF space from cavum septum pellucidum and cavum verde? A. Position between the frontal horns of the lateral ventricles. B. Posterior extension between the fornices. C. Does not extend anterior to foramen. 72. C. Does not extend anterior to the foramen of Monro. 73. B. Lactate peak on Mr. Spectroscopy. C. Does not extend anterior to foramen of Monro. Perfusion and spectroscopy. The neurosurgical team are keen to biopsy this lesion if there is radiological suspicion of a high-grade lesion. Which of the following radiological phi endings is most consistent with a high-grade lesion? A. Relative cerebral blood volume, RCBV, 1.5 on Mr. Perfusion. B. Lactate peak on MR. 74. A 54-year-old man presents with hearing loss in the left ear, which is of the sensorineural type. He undergoes an MRI scan of the internal auditory meaty and subsequently a full MRI scan of brain. A large extraaxial mass lesion is identified at the left cerebellopontine angle. Which of the following features on MR imaging will be most helpful in indicating that this is probably a large vestibular schwannoma rather than a meningioma? A. Enhancing dura adjacent to the mass. B. Erosion of the adjacent porus acousticus. C. 74. B. Erosion of the adjacent porus acousticus. A large meningioma at the cerebellopontine angle can easily grow. Disturbance and headache. She is 4 months postpartum. On examination a bitemporal hemianopia is noted. Hormonal testing reveals hypoadrenalism and hypothyroidism. A dedicated MRI of her pituitary gland is requested. Which of the following features is suggestive of autoimmune hypophysitis over pituitary adenoma? A. Asymmetric pituitary enlargement. B. Heterogeneous gadolinium. Autoimmune hypophysitis, and non-secreting pituitary adenomas can only be differentiated with certainty on histology. As a result, approximately 40% of patients with are misdiagnosed as having pituitary macroadenoma and undergo unnecessary surgery. Hormone production is compromised in both conditions, although a enhancement. C. Loss of the posterior pituitary bright spot. D. Sphenoid sinus mucosa.